All right, good morning. Welcome to class. Today's class, as you can see, is on head trauma for the paramedic. My name is Mark Lamery. I will be your instructor today. We'll go ahead and get started with a few ground rules. First of all, in this class and every class I give, participation is highly encouraged. Find that the more we talk back and forth, the more interaction there is, the more retention you'll have, the faster the time will go, and just the better the experience will be for everybody. Having said that, while questions are encouraged, I do ask that you be respectful of myself and of your classmates. So if you need to get my attention, if you do have a question, a comment, just raise your hand, get my attention somehow. Perhaps avoid jumping on the desk or throwing things around the room, and I will get to you as quickly as I possibly can. I do want us, as we go forward, to remember that 30 seconds from now, 5 minutes from now, 3 days from now, we could get a 911 call where you will encounter the situations that we are going to be talking about today. We'll be called to somebody who needs our help, who is depending on us, and who is depending on our knowledge and our skills to provide that help effectively. And that's why we're here, that's why we're talking about this stuff. So, having said all of that, are there any questions, problems, concerns at the outset here? Nope. Outstanding. Let's move forward. So I have here, as you can read the headline there, head trauma is dangerous and deceitful. When you're dealing with head trauma, the most traumatic injuries, the injuries where there's sheeting blood, maybe a little flaps of skin hanging down, stuff like that, are not necessarily the most dangerous injuries. But when we're talking about head trauma, we have to be concerned not only with what we can see externally, but what is happening inside. For that to work, we need to know a little bit of anatomy and physiology. We need to understand about mechanisms of injuries. And we need to be able to predict what is actually happening with our patient and what is going to happen with our patient within the next couple of minutes. Does that make sense to everyone?
Yes.
Outstanding. All right, so we're going to start with a scenario. It's right there on the board for you. You can follow along. We're dispatched to a local residence for an 80-year-old male. Get the call from his wife. The history is that there was a fall. The fall was unwitnessed. He just told her about it. He doesn't remember if he was knocked out. And the patient's wife says that he seemed fine, but now he's acting agitated, verbally abusive in a way that he never does. So, right at the outset, you've come through the door, you've heard this. Do we have concerns about this patient?
Yes.
Absolutely. What are we thinking on our initial impression? Is this a rapid transport? If so, where do we want to go? Any ideas?
Trauma center, probably.
Trauma center, absolutely. And just for quick review, where we sit right now, what are our closest trauma centers?
Research.
Research is one. What's the other close one? Center Point, absolutely. Okay. So, we're looking at our patient, we're seeing he is in fact agitated, maybe using some profanity, just acting in a way that is completely not like he normally is. So, in physiological terms, what do we suppose is happening to his patient? We need to look here for the link between the physical injury, what is physically happening inside the brain case there, and the psychological symptoms that we're observing. So as you see him, see maybe a little bump right here. That's it. No blood, no gaping injuries, nothing like that. So let's start with this. What questions can you ask that are going to help us gather the information we need for a differential diagnosis or a field diagnosis, if you prefer that term? Can you think of any questions you might ask?
Any loss of consciousness, any history of altered mental status?
Very good, yes. That's very relevant. We're talking about an 80-year-old
Any
male.
blood thinners?
Blood thinners, and that is absolutely going to drive our transport decision as well. If he's on blood thinners, no questions, no debate, he needs a trauma center. But also, yes, does his history include dementia, maybe psychological problems? Is this something that has happened now, today, for the first time? Or is this part of a pattern that exists for this patient?
Maybe alcohol.
Yeah, absolutely. Not only alcohol, but again, we're talking about an 80-year-old man. Is he on prescription medications that may be explaining this? So we talked about a transport decision a moment ago, but can we agree that once we get a good analysis of this patient done, that we're talking about a rapid transport, probably to a trauma center? Would anyone do anything different? Outstanding. What do you expect the hospital is going to do for this patient? And the reason I ask that is we need to know which hospitals are appropriate. So what do we expect to happen once we wheel that patient through the door? Scan his head, absolutely. CAT scan. So we're going to need to go to a place that has that available. In addition, we're going to need to go to a place that has neurology available. That's cut.
It's a